Well, the great thing about being the fifth speaker in the session on this topic is that pretty much everything that I need to say has already been said by the other speakers. And the downside is that all the slides with the papers and charts and evidence you've seen already. It's interesting how mechanical circulatory support, temporary mechanical circulatory support, was first really invented to support patients after cardiac surgery. So this is nearly 50 years ago when the Bakey had a patient who had a double valve replacement, could not come off bypass, and he implanted this temporary pericorporeal device that goes into the left atrium and pumps into the axillary artery. And she was supported for about 5 days, and she was able to be weaned and left hospital alive. So she was the first successful bridge recovery after post-cardiotomy support. But of course, as we've heard today already, the outcome people are very concerned about. There are lots of problems. Over the years, we've heard about the very high mortality, high morbidity associated with temporary mechanical support. So as things progressed, is it worth pursuing? Well, I'm going to have a look at 4 papers and share with you some of my thoughts about these publications. In fact, over the years, even though a lot have been written about temporary mechanical circulatory supports, a lot of the publications are a mixed bag of patients with various indications for support. So they may be post-cardiotomy, but actually a lot of them are acute cardiogenic shock after myocardial infarction or post-transplant primary graft dysfunction of primary graft failure. So there are not many publications purely looking at post-cardiotomy cardiogenic shock, but I've selected these 4. And the other thing is that sometimes you see people quote data from 1990 or 1995, and that's because there is a paucity of data. And these 4 publications are from the last 10 years. So first of all, perhaps our American colleagues might be able to clarify for us, but I was really impressed with this paper, which is a study of the STS database, of the National Cardiac Database. And it was, even though it was published 10 years ago, they quoted 5,700 patients who required mechanical support post-cardiotomy. And because of this large number of cases, they were able to break down into sort of subgroup analysis and look at trend data and so on. So this data collected over 10 years in nearly, I think, 1.6 million patients who've undergone open heart surgery, and of these, 0.3% needed mechanical support after cardiac surgery. So roughly 1 out of about 350 patients after cardiac surgery requiring mechanical support. And they analyzed it by breaking it down into 4 2.5-year cohorts. So each cohort for 2.5 years still had over 1,000 patients. In terms of outcome, the commonest adverse event they saw was prolonged ventilation, closely followed by renal failure and bleeding. So 20% of their patients required reopening for bleeding. And when we look at the 4 periods, 4 2.5-year periods, we can see that the mortality trend came down very nicely. So in the first cohort, we saw a mortality of about 60%, falling to around 40% in the latest cohorts. Now, I have to say this is quite impressive. And this is actually the best survival data that I have seen for mechanical support after cardiac surgery. And bear in mind, this was published 10 years ago. This is all the more remarkable. When they looked at the risk factor for mortality after mechanical support for post-cardiotomy shock, you have all the usual things, salvage procedure, people pour LV beforehand, and consistent with pretty much all the other studies is patients having complex cardiac surgery or aortic surgery who fare worst. Patients who have bypass graft, running into difficulty, seem to do better with mechanical support, whereas patients with valvular surgery or multiple valvular surgery seem to do worse even if you try to support them afterwards. But the other thing which is somewhat surprising is when they look at outcome according to age. And when we look at mortality, you see that the red bar shows you that mortality is actually highest amongst the youngest patients who are supported post-gardotomy. And in the 80 to 90-year-old group, they actually have the best survival with the mortality of only 30%. Now, I think the only explanation for this is that those patients were clearly highly selected, and they're probably the fittest of the patients who undergo cardiac surgery, who then run into unexpected problems. But in any case, this has not been found in any of the other studies on post-gardotomy mechanical support. And the authors concluded that the reason why their outcome have improved over the 10-year period is because they've moved from using continuous flow to pulsed outflow, which is actually a little bit odd because in the last 10 years we seem to have gone the other way. They have better equipment, better cannulae, and seems that it is overall better patient management, use of nitric oxide, better understanding of use of anticoagulation, CVVH support, and so on. But I think this paper really seems to be putting forth some quite different messages compared to a lot of literature on post-gardotomy, particularly in terms of age not being a risk factor for failure. So the authors concluded that certainly in their view, with a 60% hospital discharge rate after post-gardotomy mechanical support, this is something which they feel it's important therapeutic intervention for people who run into problems. Now, crossing the pond, coming to Europe, the biggest series that I found was from Leipzig. And Leipzig, in their usual fashion, being a huge center, large volume, they do lots of everything. And I think they were being brutally honest. And this actually perhaps shows the real world experience that a lot of us are seeing with mechanical support after cardiac surgery. So this is a 12-year study looking at 40,000 patients who've undergone cardiac surgery at Leipzig, and they had over 500 patients who needed mechanical support. So this is a rate of 1.28%. And in my mind, that's actually a very high percentage. This is about 1 in 80 patients that they operated on that they had to put on mechanical support. Bear in mind, the American series showed 1 in about 350. So in Leipzig, they are using mechanical support at the rate is nearly 4 times that of the US centers overall. They chose to use ECMO as their primary means of support. And of the patients that they did support, 40% were supported from the primary operation and nearly 60% were supported later on. So this is after patients coming out of theater, back on ICU. It may be sort of late development of their heart failure, and sometimes it is cardiac arrest once the patients are back on the unit or back on the ward. And when they use ECMO, 60% were done with central cannulation and 40% with peripheral cannulation. Interestingly, their support duration is quite short, median of 3 days. They had to do cannula revision in 1 out of 8 patients, oxygenation change 1 out of 16 patients. They did attempt to bridge patients directly to transplant after post-cardiopathy shock, but of the 5 that they did bridge transplant, only 2 survived, and the authors concluded that this is really not a realistic option. They've also done some bridging from ECMO onto longer-term devices. 15 of their patients received longer-term implants, but only 3 of them actually survived. Overall hospital stay, 16 days of the survivors. Hospital stay was 27 days. Now, I think it is when we come to look at the adverse events, which is sobering. Average drainage blood loss in the first 24 hours per patient, 3 liters. Average in the first 48 hours, 4.2 liters. Average amount of red cell transfusion, 30 units per patient. FFP, platelets, and so on. So this is hugely resource intensive. And I think those of you who have actually pursued this activity will probably share these pain. Now, when we look at the adverse event rates, again, I think they are being very honest. The rethocotomy rate, reopening rate is 80%. Renal replacement therapy is required in 65% of their patients. And earlier, Neil talked about leg ischemia. As you can see, in the patients who had peripheral cannulation, who did not have a reperfusion cannula placed, 23% of their patients experienced leg ischemia, and 11% require fasciotomy for compartment syndrome. So a rather sobering and shocking range of complications. They managed to wean 63% of patients on support from their ECMO support, but less than half survived the hospital discharge. So overall, the 500 odd patients, only 24% left hospital alive. Those who left hospital alive, about 2/3 were still alive at 1 year, and just over half were alive at 5 years. When they looked at risk factor for poor outcome, they certainly found that age was a significant factor. An age over 70 had an odds ratio of 1.9. Diabetic patients also did worse, but as I said before, people with just isolated coronary disease undergoing revascularization, they actually were the ones who were more likely to survive should they develop post-cardiotony shock and needing support. Whereas patients with acute aortic dissection seem to do worse. There's a trend towards poorer outcome. What they found was that femoral venous cannulation appears to be a risk factor, and patients requiring ECMO revision and patients requiring high lactate, patient having persistent high lactate. I think this is all to do with inadequate flow. So if you put a patient on ECMO, clearly you only revise your cannulation because you've got poor drainage and you don't have enough flow. Persistent high lactate means that you are not having adequate oxygen delivery. And venous femoral cannulation, usually you have less good venous drainage. So I think all these risk factors that they're pointing out is to do with inadequate flow. So Leipzig made it very clear that in their approach, they feel that they don't want anybody to die on the table. They want to give everybody a chance. And that's probably why they have a fourfold rate of using ECMO support post-cardiotomy. So they don't use, even though they have seen this poor outcome, they still do not use age as a cutoff for selecting patients for support. However, what they do say is that they make a very quick early assessment. And if there is no early improvement within the first 24, 48 hours, they will do a one-way wean. And that's why we see that the median support duration of only 3 days. But their philosophy is that they want to give every patient a chance, but if they don't appear to improve quickly, they will pull out early on. Now, what about in the UK? A survey's been mentioned earlier, but actually I found a different publication. The survey was actually done for with returns, or at least assuming return from every unit. It was actually direct telephone contact. So this was done over covering a 1-year period of all the 45 cardiothoracic surgical centers in the UK. First of all, asking teams whether they do have temporary mechanical support after cardiac surgery. And it's interesting that 43 out of 45 units said that they have some form of temporary mechanical support, either in the form of ECMO or ventricular assist devices. But of those units that have got access to these devices, a quarter of them said that they would not use it and they would not consider it for post-cardiotomy support. So only 2 units out of 45 said that they have no means of supporting patients. And in that 1 year period, it was estimated that 66 patients in the UK required temporary mechanical support with a rate of 0.24. And so this is not too far off the rate that we saw in the American STS paper. And range of devices, most units use a biomedical pump, and I think more and more units have access to central mag. And then there are the growing number of centers using Impeller. There's 1 or 2 centers with the Berlin X-Core as well. And half the patients required only LVAD support, and of the other half, 25% needed needed LVAD and 25 needed BiVADs. And across the UK, we're seeing about a 40% survival rate to hospital discharge. And again, just like the Leipzig experience, we do see that while some patients die on support, others die after weaning from support. The authors here concluded that the difficulty is looking at this is that we do not have a prospective data collection like they do in the US on the STS database, and they called for a register to audit usage and outcomes of mechanical support after cardiotomy prospectively. And I think there's been speakers saying that we really need national guidelines and so on. The trouble is that no unit agrees on criteria, inclusion, exclusion criteria. It is, at the moment, I think there is not enough evidence either to help guide developing these protocols. So I think this is also an area which is very unlikely that we are ever going to get prospective randomized trials either. And so I think at the end of the day, it may fall on a group of enthusiasts to sit down and make a consensus sort of expert statement. And we have to start somewhere, and that's probably how we can start. And then finally, the most recently published series in the UK is from the Scottish group of the Tsui Scottish Centre. They look at a 2-decade, over 20 years of use of mechanical support after cardiotomy. But actually, in that 20-year period, only 4 were used in the first 10 years, 24 were actually done in the most recent 10 years. But their rate of use is very low, 0.1%. So this is much lower than the average UK rate and lower than the US rate. And between the 3 Scottish centres, they favour the use of central ECMO and peripheral ECMO, and only 4 patients have temporary ventricular assist devices. They found a hospital mortality of 60%, so survival 40%, very similar to the UK survey, and the range of complications that they've experienced very similar to other published reports with bleeding, renal failure, limb ischemia, and stroke. So going back to the title of the talk that I was given, is it worth the effort? I think decision of whether to use mechanical support after cardiac surgery remains very difficult, because you've got a patient who's not coming off bypass. You know that with a balloon pump and lots of inotropes, if you can't come off bypass, this patient is certainly going to die on the operating table unless you do something else. But at the same time, you're always thinking the impact of putting someone on ECMO, and even in a transplant center, it causes mayhem. It is not just in the non-ECMO, non-transplant center. Even in transplant centers, it causes mayhem. And you think about the chance of success versus futility, and you're always weighing it up, and it's already been mentioned, your sort of emotional attachment to the case, because you've already spent 10 hours in the operating room, and you've spoken to the family, you know the patient personally. So it's quite difficult to make a rational and logical judgment. And previous speakers already pointed out it's actually very valuable to involve other colleagues who can independently think straight and help guide a sensible decision. Some of the other points that have been touched on is, well, people ring up and say, we have nothing to support the patient. Well, actually, that's not entirely true. If you can do cardiac surgery, you can do temporary mechanical support. All you need is an arterial cannula, a venous cannula, some tubing, a pump, and an oxygenator if you want to do ECMO. And so I think leaving a patient off bypass in low cardiac output state with a balloon pump and inotrope for several hours, well, that patient is doomed. It doesn't matter. By the time you ring people and say, can you help, and you find someone who's able to help, your patient is going to be so acidotic. Your patient is going to be with high lactate. They already have developed gut ischemia, and it's actually too late to try and support those patients. So rather than say that, oh, well, we have nothing to support the patient, that patient should just go back on bypass to begin with. You need to maintain full flow, you need to maintain oxygen delivery and keep the organs working, and try to avoid using lots of vasoconstrictors. And if need be, you can support the patient for 24 hours. You can buy time. So I think there is certainly no evidence to say that one particular device is going to give you better outcome than another. I think in the first 12, 24 hours, any form of surgery support to maintain adequate oxygen delivery is the key. Where should these patients be managed? And again, as I said, I think this is difficult. People ring up transplant units assuming that they have unlimited resources. And it becomes a very difficult discussion. And not only have I received these direct requests from colleagues around the region, I've also received phone calls from different transplant unit directors ringing me and say, I've got this phone call from a friend. It's really difficult. I want to say no, but I'm worried about upsetting people. So I think all the transplant centers are put under this pressure to accept patients. But as we can see, if we do 45,000 open heart operations in the UK every year, we're going to see several hundred people with post-cardiectomy problems. And if we expect the 5 or 6 transplant units to take up these patients, it just means that the transplant units will be paralyzed, and they will not be able to actually perform their duty as a transplant unit and make use of donor organs and do transplants. And the transplant units are actually constantly being scrutinized and challenged by NHS Blood and Transplant to say that, why aren't we accepting more organs? Why aren't we doing more transplants? Well, if we actually use the facility to support patients with a 30-40% chance of survival, whereas post-transplant survival is 90+ percent, it's very hard to justify turning down a heart and do a routine heart transplant when your beds are full of post-cardiectomy patients. There's no doubt that the transplant units have developed more skill and expertise and experience in looking after these patients. So I think what we really need to think about is setting up a UK acute heart failure network, so that we have hub and spoke arrangements, discussion before surgery, discussion at the time you run into trouble, perhaps have a set of technical guidelines and protocols of how to do it, rather than trying to talk people through how to do things when they've got a patient on the table and try and put things together. They need dry runs, they need to look at what equipment they have on the shelf, and before they actually run into problems, so that they have a game plan of what to do when the need arises. Then cost, and who should pay? Well, I think there are several ways of looking at it. An average sized unit in the UK doing perhaps 800 pumps a year, you might see 2 or 3 patients. If you look at a percentage of 0.3% patients needing support after cardiotomy, you will have 2 or 3 patients a year. Now, even though each of these patients is going to cost you tens of thousands in terms of equipment and bed days and so on, if you average it out, the cost per patient of your 800 patients is probably in the region of a couple of £100. Now, I know that a lot of surgeons will happily use a range of disposables during a routine cardiac surgery, be it arterial cannula or glues or other hemostatic agents, which are £150, £200 a shot anyway. So it is almost like an insurance policy. If you actually set aside your £200 or £300 per case, in the 1 or 2 patients that you have every year who need support, you've already got that resource. As already mentioned, none of the transplant units are actually funded to provide mechanical support for post-cardiotopy patients anyway. And we all absorb that cost through doing everything else that we do. And so to expect them to actually take on other units post-cardiotopy support means that not only do we need to put aside £200 per patient that we do to support our own patients, we need to put aside £1,000 per patient that we do to support other people's patients. So I'm going to wrap up. And I think with the numbers that we're looking at, it is, whilst it can be done, there will be exceptions to the rule. In most cases, I think the best hope for these patients is a bridge to recovery if their hearts do not work at the end of the operation. There will be the odd case that we will be able to justify bridging them to a long-term device. There will be the odd case that we can justify doing a transplant. But by and large, in most patients, post-cardiotopy mechanical support is the intention is to bridge to recovery. And every unit will really need to have a think about their own threshold of their experience of how and which patients that they will consider supporting. I think when we look at literature, there's this very broad range of survival from 25% to 60% in the case of the US series. It's clearly partly due to some units being more experienced and have the expertise, but I suspect a lot of it is actually common sense and patient selection, and excluding the harshly those who have no chance of survival, whatever you do, to remove those sort of futility patients is probably how we actually achieve a somewhat more acceptable survival rate. But for those who do survive that episode, they do seem to do well in the long run. And we hear lots of anecdotes about people who've survived their support, and then 3 years later, 5 years later, they still are alive, but not only alive, but they actually have a good quality of life, because unless their hearts actually recover, they're not going to survive the episode anyway. And as I've already mentioned, I think outcome depends on unit experience and patient selection. Thank you.